Now I invite Dr. Gargi Sathish, Professor, GMC Kottayam, for her talk on optic disc analysis in glaucoma. Over to you, Gargi.
Thank you so much. Going to my topic, which is optic disc analysis in glaucoma. Now, you all know that glaucoma being an optic neuropathy, the structural damage visible as optic nerve head and peripapillary changes precede the functional damage like perimetry changes. How do you evaluate? Any sort of ophthalmoscopy will do, but the slit lamp biomicroscopy with its good stereopsis and magnification is the best. Use a similar method every time and do it with pupil dilated. A stereo photograph of the optic nerve head is a very useful tool. It gives an objective record as well as we can compare and follow up. But more than that, all of you may have seen that some abnormalities like RNFL defects, splinter hemorrhages, etc. may actually be picked up by a photograph than on our clinical examination. Now think of the optic nerve head or analyze the optic nerve head under the following headings. You keep it systematically so that you don't miss out on anything. So first is the disc size, which is very important because the size of the disc will determine the size of the cup disc ratio and the neuroretinal rim. So if it's an average size disc, the Isint rule etc. Will stand good. But if it's a large disc, the cup is also going to be large and we may overdiagnose glaucoma. Similarly, you all know that in small disc, even the slightest enlargement of the cup could be glaucomatous and we may underdiagnose glaucoma. So, disc size is a parameter which should always be kept in your mind. And with experience, we can always understand what type of a disc it is. Now this, with the advent of OCT, we don't usually do it, but still you can know that if you have a Hackstreet model with this graticule, you can easily measure off the size of the disc and multiply it with a correction factor for the lens used. Similarly, the direct ophthalmoscope Welsh line 5-degree aperture has a diameter of 1.5 millimeters and you can compare the disc size with that and classify the disc. Another thing which you should keep in mind is that the disc itself could be asymmetric between the two eyes, which can result in a cup asymmetry and we may again misdiagnose glaucoma. So that has also got to be kept in mind and looked for and documented. The shape of the disc is classically vertically oval and all our rules like the Isint rule stands good in such a shape. So any abnormality in shape like in myopes, tilted disc, all our usual rules are not valuable and you may have to probe in further to diagnose glaucoma. So you have to document abnormal shapes also. Now, the cup. You all know the contour is more important than the color, etc. And how do you know the contour? It is by observing the blood vessels. So the blood vessels take two turns. One is at the bottom and that one is at the top, and that second kink is the edge of the cup. So that is the contour of the cup. And this is the age-old classic teaching which according to me stands very good with a CD ratio more than 0.6, deep excavated cups and an asymmetry between the two eyes of more than or equal to 0.2 definitely suspect glaucoma. Now the most important parameter is the neuroretinal rim, and the disc being vertically oval and the cup being horizontally oval slightly displaced upwards gives us the classic Isint rule, which everybody knows. Now the NRR loss actually occurs sequentially, usually inferotemporal, then supratemporal, then the temporal is totally gone, and finally we are left with a nasal remnant of the NRR. Sometimes it can be a diffuse sort of loss with a concentric enlargement and we may get confused, is it a large physiological cup? But some sort of a preferential loss as well as Isint rule violation usually occurs. Focal loss is a characteristic notching. We have to look out for it, especially in a shallow cup. Then only we sometimes see notching. And in a deep cup it is easy, and usually again in the inferotemporal and supratemporal aspect we see notching. Color is very important. Any pallor of the neuroretinal rim, think outside glaucoma. Usually a neurological cause has to be suspected. The retinal nerve fiber layer, don't never forget the RNFL. You can beautifully see the defects of RNFL if you look for it under red free, and a localized RNFL defect is highly specific for glaucomatous optic nerve damage. and they're more commonly encountered in the normal tension group. It could be wedge-shaped or slit defects, and the slit has to be broader than the blood vessels to actually call it a defect, because it can occur physiologically too. And again, in the supratemporal and infratemporal, where they are the thickest, that is where the defects are also seen. And RNFL defects are sensitive indicators of early optic nerve damage, and they can be seen before the disc changes or the notching, etc., and hence much before perimetry changes. So that is why they are important. So look out for them in the areas of notching, and if you see hemorrhages, 6 to 8 weeks after the hemorrhages, you may see an RNFL defect rising there. If in later stages there is a diffuse loss, the blood vessels will start looking more prominent, and the papillomacular bundle, which is affected last, will appear very bright. Hemorrhages on the disc are very important. Splinter hemorrhages perpendicular to disc margin within 1 disc diameter. Again, these findings were very common in the normal tension group. They are transient, usually around 12 weeks, and then they disappear, and they indicate a progressive glaucomatous damage. If you see a disc hemorrhage, it means the disease is not under control. And in an ocular hypertension patient, it is a positive predictive factor for the development of POAG. Peripapillary atrophy, don't forget the distinctive central zone beta and the peripheral zone alpha, which again is more prominent in the NTG group. Then these signs nobody usually misses, but look out for bayoneting or the double angulation. Look out for the bearing on the top picture, you see the circumlinear, and then the bottom the vessel has been bared. Look out for an overpass cupping, the typical nasalization, laminar dot sign, and finally the large beanpot cupping. Usually all my PGs write these classic signs, but the initial important steps are usually missed. So systematically analyze the optic nerve head to reach the decision. Is it glaucoma or not glaucoma? Whether we have to start treating or alter the treatment. Is it progressing or stable? Or even Thomas Sir said, we may find out other causes of the field defects and OCT defects, like a toxoplasma scar he was showing. So the decision solely rests on you. Remember always, you are the boss, your clinical assessment is the best. Don't totally depend on machines or computers. They are just there to help you. Thank you so much.
Thank you, Dr. Gargi, for the talk. Excellent talk on optic disc analysis. And thank you for enlightening us for the information that the examiner is the boss, not the machines. Thank you.
So I invite Dr. Sarita V.K., Professor of Ophthalmology, Government Medical College, Kottayam, for her talk on gonioscopy.
Good afternoon, everyone. Thank you, madam. The topic is gonioscopy. Straight away coming to the indications. Basically, it is to differentiate an open angle from a closed angle and to study the topography of the angle and also use for therapeutic purposes. A word about the principle. Normally, we cannot visualize the angle structures due to total internal reflection at the cornea-ear interface. Coming to the principle, the gonioscope changes cornea-ear interface to lens-ear interface, changing the critical angle, thus permitting the view of the angle. There are two types of gonioscopy, direct and indirect. With direct lenses, the light is refracted from the angle is observed directly and we get an erect image. With indirect lenses, the light is reflected by a mirror within the lens and an inverted image is obtained. We usually do indirect gonioscopy and this is the standard procedure. As I told, with indirect lenses, the images viewed are reversed by 180, but the right-left orientation remains the same. From the figure, you can see that the pigmentation at the 12 o'clock is seen at the inferior mirror at the 6 o'clock position, but the PA is seen on the same side. These are the indirect gonio lenses, Goldman. We usually use Goldman 2-mirror lens, which has got a flange, and it is used for manipulative gonioscopy also. These Zeiss, Posner, and Sussman, they are mainly used for indentation. Regarding the procedure, the key points are the gonioscopy should be preferably done in a dimly lit room. Regarding slit lamp adjustments, there should be minimum illumination initially and with 10x magnification. Use a thin short slit beam. The purpose is it should not cross the pupillary border, producing meiosis, and which can artifactually opens up a narrow angle. First of all, you have to explain the procedure to the patient. After anesthetizing and filling the lens with the viscoelastic, you can examine the lens for any bubbles or oil marks or scratches. Then the slit lamp adjustment is made. You have to reduce the slit beam and ask the patient to look upwards, pull the lower lid slightly down and place the lens. You can see we are supporting the gonio lens with 2 fingers and the third finger is used as a support to the headband. Then first of all, you have to focus the inferior angle in the superior mirror because that is the widest angle. Grade the angle, then you can increase the illumination, you can broaden the slit beam and look for the final details. As you all know, this is the normal angle anatomy. Starting from the Schwalbe's line anteriorly, the non-pigmented and pigmented trabecular meshwork, scleral spur, ciliary body band, and finally the root of the iris. So what is an occludable angle? When the non-pigmented trabecular meshwork is not seen in 3 quadrants of the angle, without indentation or manipulation in the primary position, it is called an occludable angle. The corneal wedge can be used to, the apex can be used to identify a Schwalbe's line so that we can differentiate a pigmented Schwalbe's line from the trabecular meshwork. What about manipulative gonioscopy? It is done with Goldman lens and useful in convex iris configuration, and over the hill view is obtained in a narrow angle, and the patient is asked to look towards the mirror and the mirror is tilted towards the angle being viewed. Coming to indentation, we usually do with Zeiss or Sussman lens, which has got the same radius of curvature as that of the cornea. The apex is indented and we can differentiate an appositional closure from a synechial closure. This is the procedure of doing indentation. This is a closed angle. We can see after indentation the angle is opening up. Coming to the disadvantages, these indirect lenses require a coupling medium. It has got a mirror image and inadvertent pressure can open or close the angle. These are the direct gonioscopy lenses. The advantages are we get an erect panoramic view which is relevant for surgical procedures. There are different angle grading systems. The most popular and usually used is the Schaffer system, which is based on the angular width of the angle recess, and when the angular recess is less than 20 degrees, there is a chance of closure of the angle. How do we represent angle structures? We represent angle structures by the most posterior structure seen first in the primary position and then on manipulation or indentation. We can also represent the trabecular pigmentation, convexity of the iris or peripheral prominent role of the iris, and subtle features like peripheral anterior synecdoche or new vessels in the angle. This is a representation of the goniogram. You can record the finer details like NVA, goniosynecdoche and peripheral anterior synecdoche. What are the contraindications for gonioscopy? If there is acute trauma to the globe, bullae, ocular surface infection and epithelial defect. There are some of the gonioscopic findings. Iris processes are fine filiform, they don't obstruct the underlying structures and follow the contour. Unlike peripheral anterior synecdoche, which are broader, tent-shaped and obscure the angle details. The new vessels, they are fine, arborizing and crosses the scleral spur. We can see the double hump sign on Plato iris, pigment dispersion, concave iris configuration, Sampolasi line and a homogeneous dense pigment. In pseudo-exfoliation, there is patchy pigmentation of the trabecular meshwork. This is the prominent Schwalbe's line in accent field rigor. and iridia, there is anteriorly displaced rudimentary stump of the iris. These are the irregular pigmented widening of the trabecular meshwork in angle recession. Also, we can make out cyclodialysis and foreign body in the angle. Don't remember to check the patency of the ostium after trabeculectomy. Cleaning, usually we clean with soap and water. The take-home message is, in ideal conditions, gonioscopy should be done routinely for all patients above 40 years. It is a must before making a diagnosis of glaucoma, and repeat gonioscopy at regular intervals during follow-up of your cases. Thank you.
Thank you, Dr. Sarita, for your elaborate but basic things how to do a gonioscopy. Because gonioscopy is critical in the diagnosis of all forms of glaucomas, which will give an information about the increased intraocular tension, and also it is critical to see the potential causes, determination of therapy. So for therapy as well as cause of increased IOP, you can find out by gonioscopy. So all general ophthalmologists should know how to do a gonioscopy.